Cost has to be decreased. So whatever measures can be done to decrease the cost of the procedure is worthwhile. But the procedure itself is not going to go away. It's impossible because it is a constant need of the community. Again, that is a health policy question that we face all the time, that what is futile and what is not futile. And the perspective of futility, as you can imagine, comes at different levels. So the patient, family, doctors, and health economics, hospitals define futility differently because everybody has a different goal. So they define futility in a different form. We wrote recently in Circulation a letter to explain this, that what is really the futility. To a consumer or to the patient, if he thinks that this was worth it, a procedure, then it is not futile, obviously. But to a doctor, if we did a procedure and the patient died, that can be considered futile. And to the health economists, if you ask them and you say that, okay, you spent $100,000 to prolong life by 6 months, that could be considered futile because there can be other therapies that may be less costly and prolong life more. And if we have to choose between the two, maybe we should use those other therapies for different patients and not for this patient. But when an individual patient is referred to you, the family, the patient, they all feel extremely passionate about saying that if there is a non-invasive treatment for their loved ones, where nowadays we can do almost without anesthesia, local anesthetic, 2 days, 1 day hospital stay, and they are likely to feel better, how are we going to be able to say to them that we are not going to do this procedure? We did a 104-year-old gentleman to replace the aortic valve, and he still works. He goes to his job and he does, he's mentally there. He is socially participating in all the events. And he says that he's out of breath and he cannot function. So he's 104 chronologically, but he looks good. And how can we say no to him? Not in the current terms, they have never said no, because most of them are Medicare patients in the United States. And insurance companies have not yet said no just on the basis of futility. We are extremely cautious as a medical community to say that people who have the lifespan that is less than 6 months or 1 year, we should not do this. So people who are on chronic dialysis, very old, in a nursing home, and demented. So there are two groups of patients. One is the people who are sick with aortic stenosis, and the second is the group of patients who have sickness but also have aortic stenosis. So they are sick with other things, but they happen to have aortic stenosis. It is difficult to sort them out. It is not as easy as it looks that, if you're sick with aortic stenosis, treat them, and if you are just happen to have aortic stenosis but other sickness, don't treat them. But if we can somehow get an understanding of who will get better if we take the aortic stenosis out of that equation and live longer, improve their quality of life, then these are the patients you should treat. The real challenge is trying to find or fine-tune these expectations from the patient, family, and doctors. Like anything else, the heart team approach is critical because people who do procedures have to not only see the patient, but understand the expectations of the patient, family, and the time that we can spend with the patient is obviously limited. So it is a fine balance between knowing everything about the patient, trying to make the right decisions. Procedurally, it is taking 45 minutes to do the TAVR currently. But to work these patients up and take care of them afterwards and to make sure that their expectations are met really takes 45 hours probably. So it is a big difference in terms of the surrounding work that needs to be done and the procedure itself that needs to be done.